So welcome everybody. This is DocTalk, so COVID-19 vaccine for kids. My name is Jeff Malmgren. I work with Primary Care Networks who host the DocTalks. Just so you're aware, this session is being recorded and it will be available afterward on our website on the www.burnabypcn.ca website. So if you wanted to look at it then or share it with your friends, it will be there. We also, just some housekeeping items. If you have questions, please make sure that you put them in the chat, and we'll do our very best to get questions answered at the end of the session as we possibly can. If there are questions that we don't get to, we will do our best to answer those questions and put them back out to the group as a whole at after the session is over. So without further ado, I'd like to introduce our presenters today. We have Jen Meze with us, who has served as the Burnaby DPAC Chair and President of the BC Confederation of the Parent Advisory Councils, but is now the Chair of the Burnaby Board of Education. She's a mother of Burnaby School students, and she's been an involved parent right from the outset with her time with her kids there. So it's really great to have Jen with us. And Dr. Brendan Narang is the Chair of the Board of Directors of Burnaby Division of Family Practice. He's also on the Chair of the Steering Committee for the South Asian COVID-19 Task Force, where he co-founded the This Is Our Shot Vaccine Confidence Campaign across Canada. He's a clinical assistant professor with the Department of Family Practice at the University of British Columbia, a medical contributor for Global BC and CKNW 980, and he's a family physician for the Reach Community Health Center. So it's great to have both of you here, and I'm going to hand it over to Dr. Narang for a presentation, and then we'll look for some questions after that.
First of all, thank you everyone for joining us. I know that there's a lot of questions about vaccines, especially for children, especially in the context of Omicron, and especially with what's happening in BC right now. And there's a lot that, to be fair, is still unknown, but there's a lot of good data we have on efficacy from trial data, effectiveness from the real world data, and safety data from all around the world. So the goal of today is just to inform you with what we know so far and try to help that guide your own decision making, especially when it comes to approaching vaccination with your kids. Now, we're not going to get into any individual advice for people's specific circumstances, because I think that's a conversation that's best had with your primary care provider. And if you don't have access to one, there are other mechanisms to get support on that. But this is more of a general overview on how we should be approaching it as families. And, for those of you who do have children in this age range. Just going to get started. So we're going to do a little bit on Omicron epidemiology, what's been happening in BC vaccine safety, and why get vaccinated. Then there's already been some questions sent in. So I expect some of these questions would be common questions we'd be getting. So I'm going to try and answer those, and then we'll make sure there's time for people to ask other questions that you may have as well. So first off, what is Omicron? So Omicron is the latest, my arrow got all messed up here, but it's the latest variant of concern, first identified on November 26th as a variant of concern. And, just the reason I highlighted that is because, we're only, 7 weeks after that right now. And so this is a kind of a testament to all the science and learnings we've had in that amount of time. Which is, a testament to the global scientific community. So why is Omicron so transmissible? There's well over 30 mutations, including 15 on the site that actually binds to your cells, and also on the spike protein, which we've heard so much more, and there's over 30 vaccines on there. So this is just a cool graphic that I came, but we're not going to spend any more time on that because that's going to get way too deep for anything we need. What we've learned about Omicron in this short time interval, that it's replicating much more in your upper airways versus the lower airways. So when I mean the upper airway, I mean, anything above the main bronchi, which are what connect to your trachea, which connects to your mouth. And that then, you have your nasopharynx, which is your nasal passage, your sinuses, your throat. So it's actually, there were some Hong Kong studies that showed that it was actually replicating 70 times more in this upper airway. And that's kind of why we're thinking it's showing the shorter incubation period, because it's making it's acting like other viruses that infect the upper airway, which tend to infect you very fast. You get pretty sick for a few days, and then you clear it pretty fast as well. And that's why these symptoms have changed as well. So this is some data coming out of the UK, which is a cool data collection app, which has been collecting data all through the pandemic, where people can self-report their symptoms, and it's being analyzed by a group of physicians and medical experts from across the UK. And we can see now that our symptoms are changing. It's more runny nose, headache, fatigue, sneezing, and sore throat, but not as much as shortness of breath, fevers, and altered smell, as we've been seeing previously in the pandemic with other variants. And this is just from a couple of days ago. And while we're not going to focus on this group today, I think it's important to remember there is a group of us out there who still, by large, cannot be vaccinated, and that's our children who are under the age of 5. There's no vaccine available for this age group. And here's some data that's come out of the US, and it's a preprint, which means it's still going to go through the peer review process, but it looked at over 7,000 infected children who have Omicron, and the average age was 1.5. And they compared it to the same age group who had been infected with Delta. And so what we wanted to know, or what these people wanted to know, is for people who have not been infected with COVID before, whether it's Delta or a previous variant, is there evidence that Omicron is less severe? And this was shown clearly in the study that for people who have been, or babies who have been infected for the first time, it was significantly less severe outcomes, and they estimated it to be around 1/3. So that's quite a significant result. And this was looking at things like mechanical ventilation, ICU admission, hospitalization, emergency visits, and Omicron was less in all of those domains. So really important to think about right now. Another thing that especially the parents here will have seen many times in their lives is something called croup, which is an infection that can lead to kids when they're around 6 months to 3 years of age. It's generally a mild illness as well. It's usually caused by other viruses, such as para-influenza viruses and influenza viruses. But there have been reports, even here in BC, that they have seen croup presentations. At the time of presentation, you don't know what the virus is that's causing it, but you know what the expected picture is, the clinical picture of it is, and the treatment pathways. So they're treating it as croup, but now when they look back at it and they've sampled some of these kids, they are seeing that Omicron is actually presenting like this, especially in these young kids. So just something to keep in mind going forward. This is just looking at the hospitalizations and deaths in BC, and this was presented by the province on Friday with data from the BC CDC. And this is looking specifically in the last year, so looking January 2021 up until January 11th, 2022. Now, I'm not going to talk about, where the graphs start going really up and down in the 60 plus populations, but let's focus on the 0 to 9s and the 10 to 19s right now, where we see the blue line is hospitalizations and deaths is the red line. And this is looking at rates per 100,000 population. So we can definitely see in the 0 to 9 population, there has been an increase in the last couple of weeks in hospitalizations. That's not translating to severe disease and death, thank God. But we are also seeing a little bit of an increase in the 10 to 19 population, but not as much. And that is likely due to the fact that the 12 to 19s by and far are more vaccinated than the 5 to 11s right now. Looking a bit closer, and one of the, I think we did receive a few questions on this, so we'll come back to it more specifically after, but I just wanted to highlight that in the last week, in the 0 to 4 population, there were 9 children that were hospitalized. 0 of them, in the 0 to 4 age group, 0 of them have gone into ICU, and there have been 0 deaths. In BC, only 2 children from age 0 to 17 have passed away from COVID-19 since the beginning of the pandemic. So I think that's important to recognize as well. And we'll look at a few more of these numbers when we get to the questions after. From what I understand, though, there's only one vaccinated case in BC hospitals in pediatric populations in someone in a child who is fully vaccinated, and that would be a 12 to 17 because the 5 to 11s haven't had their opportunity to get their second dose yet. Sorry, these graphs got a little messed up too, but this is just looking a bit more. I looked a bit closer in what is the latest hospitalization rate, especially and critical care rate in the age 5 to 11. So the latest numbers we have is on January 10th, which was a week ago today. That rate was 2.2 per million. And so that's looking at 1 million population. So for every million children in this age range, which we don't even have that many, two of them would get admitted to hospital. And if we look at the critical care rate, for months on end now, it has been 0. But the max that it's gone up to is 0.4, and that's also out of 1 million. So we're talking really, really low population rates here. And same as hospitalization rate and critical care rate in the 12 to 17 population. So looking at the hospitalization rate, and the reason I'm showing this is to demonstrate the difference in our hospitals right now when we look at vaccinations. And this is kind of a spot prevalence. So we're looking at January 10th again, 1 week ago, and the rate for getting hospitalized if you were unvaccinated between 12 to 17 was 4 per million. So still absolutely a very low number. If you look at vaccinated, it's still much less. It's 1 per million. So, that is a huge difference, even though in relative numbers, even though the absolute numbers are still very low. And when we look at critical care rates, they're 0 for all 12 to 17s right now. And that shift is more reflective of likely because of how Omicron is going through our population right now. So let's look now, the focus of this talk. That was just a primer on it, but I didn't want to spend too much time on it. But this is let's look at vaccines. So we know in 5 to 11 age population, there's the Pfizer vaccine that has been approved for them, and that's using 2 10 microgram doses administered. Now, the study did 21 days apart, and it was found to be safe and gave about a 91% effectiveness. And this was, studies that were done back in the summer to fall of last year. And I'm going to go a bit more detail when they compared in the studies. They actually compared the 10 microgram dose, which is this 5 to 11 dose, and the 30 microgram dose, which was commonly being used in adults. And it did find that they gave similar antibody responses. So that's when we mean antibody responses, that's how we can measure how well our immune system was actually responding to this vaccine introduction. And there was a new article that came out 5 days ago in the New England Journal of Medicine, which is one of the most premier journals in the medical world, and it was looking at 2-dose Pfizer vaccines in 12 to 18-year-olds, and this was looking in the time of Delta from July to October, and they looked at cases across 31 hospitals. I think it was like 20 states or something in the United States, and they found that there was 98% protection against admission to ICU and against requiring life support. There were 7 deaths in this time, and they were all in unvaccinated teenagers. So the reason this is very complicated, and I don't want people to focus on the numbers, I just wanted to use this to demonstrate that this is how they did the study. They were looking at side effects with dose 1 and dose 2, and they looked at a 10 microgram dose, a 20 microgram dose, and a 30 microgram dose. And this was to look at side effects specifically. And if you look at it, it showed that the 10 microgram dose had the lowest side effect profile. So the biggest side effects was 50 to 70% after 2 doses was fatigue, then headaches, and then chills. Fevers themselves were relatively low. So just going back, and this is in the console, so the summary is the lower dose gave you less side effects, but the same antibody response. So that is just a bit of understanding of why the lower dose was chosen. Now, the latest data we have from the BC CDC was from the situation report, which came out December 21st, I believe. And so I would expect another one coming out this week, if not next week. And this was looking at the first 64,000 doses that were administered in our 5 to 11-year-olds here in British Columbia, and looking for adverse effects following immunizations. And there were actually none that had been reported yet. But also, we take that with a grain of salt, because sometimes there are reports of adverse events that are delayed. And in that same time period, there had been 268,000 first doses and 254,000 second doses in that 12 to 17 population since May of last year. And so, that's gives us a better understanding of how many adverse events have actually been reported here in British Columbia. And so what they found was that there was a reporting rate of about 28 reports per 100,000 doses given, and there was a total of 149 reports. Most of these were allergic events, whether it's a rash, hives, or some gastrointestinal symptoms. There were some 13 cases of anaphylaxis, which is a severe allergic reaction. And when you look at all the reports, so that's about 500,000 doses, give or take, given, there were 15 adverse events reported in this population that were considered serious. All of them were admitted to hospital and have since been discharged. So when you look at these numbers together, then this is a summary again of the 12 to 17-year-olds. And when you look at the risk of being of getting COVID among unvaccinated versus those who are partially or fully vaccinated, it was a huge difference. Sorry, my numbers got messed up here again, but it should be 134 times the risk if you're unvaccinated getting COVID-19. And then the risk of hospitalization was, 14 times for getting COVID-19 and 134 times the risk of getting hospitalized. Now, we have to remember this was all done in the pre-Omicron era. So these numbers won't be the exact same here now, but that's what we have. And then when we look at the risk of getting a serious adverse event after immunization, it was 2.9 out of 100,000. And that's for the partially fully vaccinated. Obviously, you cannot have a serious adverse event after getting vaccinated if you don't get vaccinated. Now, that's the BC data, but we have about 350,000, give or take, children in that 5 to 11 population who are eligible for vaccination in British Columbia. And what do we know from around the world? So in the States, 8.7 million doses have been given. So far more magnitude than we would be seeing here. And what did they find? They found 8.7 million doses. The side effects were common, mild, and brief, just like any other vaccination. Pain where the shot was given, fatigue, headaches. There were only 11 cases of myocarditis, which is heart inflammation, and that's been one of the big risks that people are worried about. And that risk was 0.14 out of 100,000. So that is a tiny, tiny risk. And they actually estimated it's 10 times less the risk than those in the 12 to 17 population. The most common adverse events in this study, and this was collecting data through the vaccine reporting system in the States, and they have a few different ways they can do it. There's one called VSAVE. There's a VAERS system that's set up. But the most common adverse events that were found were problems with preparing the product or incorrect dose being given. So that was, again, very reassuring. Now, one of the other things, this just came out on Friday. And so one of the things that we have to think about when we're thinking about pediatric populations or children is there's still a lot unknown. While we know the risk to children overall is very low when it comes to COVID, there has been a syndrome that's been identified, which I'm sure most of you have heard about over the last year, called multi-system inflammatory syndrome in children. And so this was a study from the CDC from July to December last year, and it was looking at, is there any protection in vaccination in protecting children against this MIS-C. And they found that the estimated effectiveness of 2 doses of Pfizer was 91% protective. at protecting children from getting MIS-C. And among the critically ill MIS-C case patients that required life support, all of them were unvaccinated. So these are, reasons that we need to think about. Why do we need to get our kids vaccinated when the risk to them is very low? This is one of the big ones in my mind, because what we don't know about MIS-C is who's going to get it, when they're going to get it, and why they're going to get it. And there's actually no correlation that has been established on if someone gets mild COVID, moderate COVID, or severe COVID, if which group is more likely to get this severe syndrome after. And so even people who had very mild symptoms, who might not even know that they had COVID, they might have been asymptomatic, there have been cases of them getting this syndrome as well. And so a bit more about that, there are lower hospitalization rates in vaccinated populations. And this is a bit summary, like my overall take about why would I want children to get vaccinated right now, knowing everything we know? So there's an ongoing lower hospitalization rate in vaccinated population. There's a reduction in that MIS-C, as we talked about, in some of the older populations, as we've seen in 12 to 17. Now, we don't have that data yet for the 5 to 11s, but what we do know is the median age of MIS-C has been around 6 years old. And like we said, MIS-C is not related to severity of disease. And in the adult populations, we have evidence coming out in some reduction of long COVID symptoms. And we still don't know what long COVID, how it's impacting pediatric populations yet. But this is, again, showing the protective nature of vaccination. We know overall vaccination reduces transmission. So while the risk to kids is low, from COVID, the risk is also very, very low from vaccination, but the benefits of getting vaccinated seems to outweigh those very low risks too. Now, I don't want to spend too much time on schools, especially because we have a school expert here with us, but there was some, I know there's been a lot of anxiety with returning to schools lately, and I attended a great UBC continuing education lecture last week from one of the and one of the speakers was one of the medical health officers, Dr. Choi, in the Vancouver coastal region. And she presented some of the studies that Vancouver Coastal Health has been doing, knowing that, Burnaby is Fraser Health, but I wouldn't expect a lot of differences between Vancouver Coastal, our neighbors to the west, and Burnaby itself. So when we looked at it, she presented multiple studies that were looking at contact tracing out of schools. They were tracking cases as they developed and how many people were they infecting, and how many, how big were these, they call them secondary attack rates, how many more people were getting impacted if a case was found in school. And also they tracked what they call seroprevalence, which is where they tested school staff, students with antibody testing to see how much exposure was actually happening in schools. And what they found, these are multiple studies that were done. So I'm not going to go through all of them, but I would encourage people who do want to watch that is a publicly available link, and I'm happy to share it after. I think it's a great watch for anyone who's concerned. But over 90% of cases in school did not transmit. So school transmission has consistently been around 1% of cases. It was more likely in what they called best friends, someone who shares a desk. And even when there was Delta, that risk was only 1.3%. And that, the best friends thing that was mentioned is these are also kids that you're likely to hang out with outside of school, in addition to when you're in school as well. And so that means, that does muddy it a bit. So now, even if we expect that Omicron is 3 to 4 times more transmissible, we wouldn't expect that school transmission rates should increase at an absolute number very much, because the baseline has always been very low. So let's get into some of the questions that were already presented. So how many children in BC have died from COVID? Does BC distinguish deaths from COVID incidentally from deaths due to COVID causal? Like, is there an established causality? So as we presented, there are only 2 deaths that have happened in BC from children. They were both, unfortunately, in 0 to 4 age population. I don't know anything more about the demographics or the circumstances that led up to it, or how early in the pandemic it was. I mean, I could probably go back and check, but I haven't been able to do that. When with the question about distinguishing death from COVID incidental from COVID causal, I wouldn't look at it through that lens, because how death reporting is done in British Columbia, and this is me, as I work in long-term care, so I am often filling out many death certificates. You put the most likely cause for the death and what was the reason for it, and so I would feel pretty confident that if the deaths that are being reported from COVID-19 in British Columbia truly represent it being a death that was caused by the virus or the syndrome or complications from the virus. So now looking at how many children have been hospitalized for COVID. We did touch on that there have been 9 new this week, and here are the total numbers. So the most hospitalized group has been that 0 to 4 population over the entire time. And but what we knew when we look compared to the deaths in that group is that many of them looks like they were admitted, they were treated, and then they successfully recovered. And that's what I've been hearing from my colleagues anecdotally as well. And then about half that, 70 each in the 5 to 11 and 12 to 17 age populations as well. How many children in BC have been hospitalized for adverse effects of the vaccine, such as myocarditis? So it doesn't say, I actually don't think there have been any, because, and this is what we had highlighted earlier, it said there were 15 adverse events reported among the 12 to 17-year-old population that were considered serious. All of them were admitted to hospital and have been discharged. Now, it is possible that some of these were related to myocarditis, but what we know about the myocarditis from the studies is that a lot of it was happening was the risk factors were, it was happening more in men or boys, more people who received Moderna, and more, and it was mostly after the second dose. So even in that data that I presented, where there were only 11 cases in 8.7 million, 70 to 80% of them were after the second dose. And in all those trials, and actually what's been happening in the States is they've been giving that second dose after 3 weeks. Now, NACI, which is our national immunization body here, has recommended 8 weeks, and that's for that very reason, which is that you don't need to be giving a second vaccine because the immune response from the first one probably hasn't settled down yet. And so you take that, so you want to minimize the risk from the vaccine, and then you look at what do we know about vaccine principles, which are after 8 the longer you leave an interval between the doses, the longer you expect your immunity to be. And that's one of the reasons we haven't seen as much vaccine waning or immunity waning in British Columbia compared to other jurisdictions, is because our interval we were one of the first ones to actually broaden that interval, even for all the adults. And so we're taking those principles, and then you weigh that up against the risk to children being lower than adults with COVID, and that's how you minimize the risk of myocarditis happening. Will school-age children eventually require COVID vaccines to attend public school? I took a stab at this and I wrote no. Honestly, I don't see how that could ever be, would be a reasonable thing for our children here, or something that would be politically feasible. So and if Jen wants to add anything to that, but I don't think that would ever happen.
I can add that it hasn't been something that has been discussed at all. We do have meetings with our public health officer in Fraser Health, and our superintendent meets with the medical health officer on a regular basis. One thing is, I know that you hear things from different jurisdictions, but BC doesn't require vaccinations for schools. It's like there's actually a form that we do fill out. Like, we have records for students, but it's not something that is mandated.
Awesome. Thank you so much for that, Jen. Let's go a couple of more questions, and then we'll open it up. And I know some have already been submitted. With the high rate of vaccinated cases of COVID, why is the COVID vaccine being promoted to help prevent COVID in children? It seems that vaccinated people are catching and spreading COVID. And I shared this graph, and this was actually something that was shared by the province too. And this is because it can be misleading, because let's say, if we look at today's number and it tells us that 50% of people in hospital have had vaccines and 50% of people in hospital have not been vaccinated. And so that can look pretty equal and give people that exact reasoning that, well, how are the vaccines working if half the people in hospital are vaccinated? But you have to look at what is that being compared against. So we're a very highly vaccinated population right now. So even if that 50% of people in hospital, let's say for argument's sake, it's 50 people, it's 50 people out of 4 million people that are vaccinated, whereas the 50 people who are unvaccinated in hospital, that's representing maybe 700 or 800,000. So that's showing that it's a tricky way to look at it, but it's not a good way at all to estimate how effective vaccines are, because they can get very misleading if you just look at those absolute numbers. I hope that makes sense, but that's how I would approach that.
That's the math that I've heard on that is, look at it this way: if 10% of the people who have been vaccinated are in the hospital, the equivalent would be almost 100% of the people who are unvaccinated in the hospital. So it's the
math can get funky.
Yeah, it can. Yeah.
Yeah, so I wouldn't focus on that part of it. I actually think it can be quite misleading, and it's in the daily reports, and so I've never actually looked at it because I haven't found it useful at all, and I know that it doesn't actually give me much meaningful information. What I do look at is when we look at the rates of hospitalization and comparing the rates between the hospitalization, critical care, and deaths for unvaccinated versus vaccines. That gives me a much clearer idea of how much the vaccines are actually working and protecting people. How many COVID vaccines will children need? Will boosters be likely? It is a 2-vaccine series, and it's a 2-vaccine series for those who have competent, or what we call normal, immune systems. So a normal immune system, just like adults. If a child is immunosuppressed, they might need 3 doses for their primary series. So right now, I think it's a bit premature still to know whether boosters will be expected for children. But what we're seeing is, especially when we're looking at Omicron, is Omicron has really gotten us to a point where we're seeing something that's moving so fast and is less pathogenic in the sense that it's not causing a severe illness in kids, that to find another variant to come along that would be super severe and transmit as fast, it just doesn't seem likely. And that's what I've been listening to a lot of virologists who study this as their life's work, and that's generally the consensus that many people are sharing, which is why people are tending to now think about this as a shift in the pandemic. And there are still some unknowns, though, is like, if you infect 10 people of any age in a room with a variant of COVID-19, you can't predict what everyone's individual immune response will be like. And so when you're looking at it at a population level, you can look at trends and say, well, will boosters be necessary for everyone? Probably not. Like we know that the pneumonia vaccine, influenza vaccines, although influenza vaccine has been given free everyone this year, but historically it's always been more recommended and funded more for high risk populations, the very young, the very old, people who have severe liver disease, kidney disease, or immune system problems, especially if their immune system can't actually generate their own response. And so I expect that boosters in the future on a larger scale likely would be targeted to the high-risk population, because the goal of our boosters going forward should not be to prevent us from necessarily getting an infection, because that is a bar that we'll always be chasing. We'll never be able to find a vaccine that eliminates us for a long time being able to get us infected. But what we want is the goal is to keep us safe out of hospitals and healthy. And the vaccines, and especially with 2 doses only, especially in the younger populations, have reached that benchmark. So we'll have to wait and see, but that's how I've been thinking about it. So the BC CDC states in its documents that serious outcomes from COVID-19 infections continue to be rare among school-age children. Why then are doctors encouraging parents to vaccinate their children against COVID-19 if it is a mild infection in children? And we did discuss this a bit earlier, but the risk of long COVID and multi-inflammatory syndrome in children, it does exist in children. We haven't seen a lot of cases in Canada. I think there's been around 270 cases the last that was, I think, a few months ago. There's so likely more now, but definitely not a huge amount in Canada. And the estimate is around 5,000 worldwide. And like we said, we still don't know what the link is between the initial SARS-CoV-2 infection and who's going to develop these other weird syndromes. I mean, there was just an article last week about another common virus called EBV, Epstein-Barr virus, and that's known as in some parts of the world as glandular fever. Here it's known as the kissing disease virus. It's the one that teenagers get. Also very highly infectious. And there's been a link now that might be one of the causes of MS. And so these are things that we've always known that for certain people who get infected with viruses, it can have immune changes. Even shingles, it's thought to be related to a virus. Bell's palsy is thought to be a virus that causes that too. So there are many long-term things we don't know about viruses. So that's why, another reason why I think it is reasonable to vaccinate highly effective, highly safe, to vaccinate people with these highly safe and highly effective vaccines. What are long-term effects? So I got this from, long-term effects of COVID vaccine. And I took this from Immunize BC because I thought it was a good way of explaining it. The history of vaccines show that delayed effects after vaccination can happen, but when they do, these effects tend to happen within 6 weeks of receiving a vaccine. This is why regulators in Canada and many other countries require at least 8 weeks of safety data before approving a vaccine. The vaccines have been in use for months now, and over 2.7 billion doses have been given worldwide. And so what I take from that is we've never really thought of long-term effects from vaccination. And most of the controversy that has come up with that in the past has been based on fraudulent data when scientists have actually been trying to mislead the public. And the biggest case of that is with the MMR vaccine and a lot of reports of linkages to autism, and that was based on falsified data that's been disproven many times. Now people have more specific concerns with the mRNA vaccine, like why is that not, is why we wouldn't know the long-term effects of that. But the mRNA itself, there's a few reasons why we don't actually think that should lead to long-term problems as well. And that's more about the mRNA as a molecule itself. It never enters the powerhouse of the cell, which is the nucleus of the cell where the DNA sits. And so it can't interact with it. It sits and this is going back to basic biology, but it sits in what we call the cytoplasm of the cell, where all the other kind of machinery of the cell is, but it's not the powerhouse, like the bridge of the starship, if you want to say, where all the action happens. So it's not going to interact with it. It doesn't have an enzyme. The coronaviruses don't have an enzyme where it can actually convert mRNA into DNA, which then would be a bigger concern. And also, mRNA is notoriously unstable. It usually degrades within hours in human bodies, but in these vaccines, they've been given some support so that it can last about 10 days, but it's like a primer. It just primes your immune system, but then it goes away. And so there's no reason to think that this technology of vaccine should be at higher risk for long-term consequences versus other vaccines. So that's all we really know about it right now. No one, again, like this is not a place where we can talk with crystal balls, but this is kind of what we learned so far and the principles behind it, which gives us reassurance. Is there a plan for the COVID vaccines to stop, or will children be required to have 2 to 3 vaccine shots per year for the rest of their lives? So I did address this a little bit before. I think it's very unlikely. I think anyone who gets a booster shot should really have a good idea and rationale behind why they're getting it. So even, and this might, hopefully not too controversial, but majority of people in British Columbia, healthy people, 18 to 29-year-olds, they've had 2 shots now, and many of them got Omicron. And now they're being faced with the question of like, well, what do I do with my booster? I had my booster scheduled from 2 weeks from now and I just got Omicron. Should I keep that appointment? And my natural, kind of my informed answer to that is, I don't think there's going to be any harm for you from you doing that, but I can't guarantee there's going to be any benefit either, because we know after you've had an infection that you have really good immunity for usually 2 to 3 months after it. And so I expect that since we know that the 18 to 29-year-olds specifically have been the highest group getting infected, working frontline jobs, so a lot of them living with their parents, going out a lot, socializing, holiday times, all that stuff, that they will get infected. Many have already, and they'll have really good immunity for a few months. And so I think they're in good position right now. So I expect to see some good data on that coming out over the next few months of, how long is that lasting? Now you balance that with the fact of what we said is everyone who gets infected, it's still unpredictable about how much of an immune response they get. And so where a vaccine tends to give a better, more predictable response. And so that you balance it with that. So if it's someone who's older, and I think that they're a higher risk of going into hospital, especially we know age has been one of the biggest risk factors, or they have some other conditions, either with their lungs or their blood or some other organs, then because I know the vaccine is safe, I have no problem telling them, hey, when you feel better a few weeks after, get your booster, because I think that risk benefit calculation is different for them. So I think it really has to be an individual decision. And, I know that we're not talking about adults right now, but I saw that there's a question about Israel giving fourth doses, and they've been going back and forth on that for like the last 2 to 3 weeks. And it's such a mess. And I don't know why they're doing it, to be honest. One of the things that a lot of these places like Israel and America who did get out and get very fast vaccine programs done is that they were in such a bad state that they gave everyone the vaccine in that 3-week interval. And like we've already mentioned, that 3-week interval has shown a lot of waning. So in a bit of it is that they're kind of chasing their tails a bit more than we have to. So part of this was we learned from the world, and this is the job of our CDC, not for any of us on an individual basis, from our CDC and from NACI to look at this and then make a recommendation about what makes sense for us living in BC right now. I think that's all I had for my question. So I'm going to stop my slideshow right now, and let's see what other questions we have.
And I just encourage folks, if you do have questions, please put them in the chat. There are some questions here. Most of them are not specific to necessarily to children, but one of them is around what you've talked about. If I've already had COVID-19 and I have natural immunity, do I have immunity to Omicron?
So now that's interesting. We haven't looked at that directly, but the answer is a definite no. And that's because many people who were infected with Delta already in the past, one of the earliest things that we learned about Omicron was the reinfection rate was super high. I think it was 5 to 5.4 times. So you definitely can't rely on that old immunity, because one of the reasons that Omicron is spreading so fast is because it's evading your immune system. It's like this little kind of nimble warrior that's getting through your immune system and infecting you. And so we can't rely on that. But on the flip side, those who have been infected with Omicron, what we're seeing is that they're actually generating a really robust and wide immune response that actually in the lab itself is protecting them from severe Delta. And so that's where it's really interesting, because this milder infection is actually giving you a more robust immune response. And I think that's why I'm, really being hesitant and making sure we're being rational with boosters as we go forward.
So, I mean, and along that leads to, then we're getting a broader conversation here, but it kind of goes to, why should I vaccinate my kids? That leads to, look, if they're going to get Omicron and it's going to make them more resistant to potentially other variants, or at least Delta. Wouldn't that be a good thing if it's a mild variant?
Yeah, but then you go into the unknowns. You don't know who's going to get sick. We have no idea about long COVID or MIS-C with kids. And so, and we definitely, there were still 22 people that passed away in British Columbia in the last 3 days. There's still over 800 people in hospital, and there's 99 people in ICU. We don't know. We have indication that a lot of that still might be from Delta, but there are definitely still people out there who are getting impacted from Omicron. And so we have to be careful when we talk about it. I'm more than happy to share information that shows that Omicron inherently is less pathogenic as a virus, but we shouldn't be saying that, we should have like an Omicron party, or, things like people used to do back in the day with chickenpox parties, because you don't know who's going to get sick from it for a lot of reasons. And we know that if you're unvaccinated, especially unvaccinated adults, the older you get, the risk is, we have no reason to believe it's any less risky than the original Wuhan variant or the original strain. And so it's still a severe coronavirus. It's still a SARS, a severe acute respiratory syndrome. So we have to be really careful with how we, think about it going forward.
And you may have mentioned this earlier, but is there any evidence yet to show that the booster will actually reduce the transmission of Omicron?
I haven't seen it with Omicron yet, but when you look at reduction of transmission, you look at it in a few ways. You look at it directly and indirectly. So there has been a lot of data in the past which has shown that people who are vaccinated still can transmit to a certain amount, but there has also been reduction in the ability to transmit. So that's on the individual level. There is some level likely from previous, and I expect that some of that will confer, although it's hard to say with our vaccines, knowing how immune evasive Omicron has been, being that it is evading the vaccine immunity and infecting people. I don't know how that relates to transmission, especially because it has a shorter incubation period. And like we said, it's sitting more in your upper airways. So you're more likely to have like a lot of symptoms over those few days, very localized, and be a runny, transmitting mess. And so that's like the direct part of it. And you look at it indirectly, if your vaccines are reducing the total amount of cases you have in a community, and we know there's some evidence coming out of the UK that if you have 3 doses booster, that you are less than likely to get infected. And that's because you have that still boosting antibody effect that will wane over time. But that's not the only part of the immune system. It's just the only part that we can measure. And so, but if you have enough people who are boosted in the community, then you will indirectly reduce the transmission, because there's less sick people. If you're not sick, you can't transmit it.
Right. And this kind of goes to this next question, which I think is a really great question. My 8-year-old had a fever and fatigue in 12 hours and then was fine for that. We couldn't get a test. Well, that's not that much of a surprise. Should we assume it was Omicron, and what should we do? I mean, this is the 8-year-old, this is the 48-year-old, how do we live in that world?
Yeah, there's a lot of uncertainty, and I think that's the exact question that we need clarity on from the province. What I have learned is I've been looking a lot at the UK stuff, because there are similarities in our populations when it's a lot of vaccinated immunity, a lot of AstraZeneca, a lot of Pfizer, some Moderna as well. And what they did see is in London, which was like the epicenter of it over Christmas, over 1 in 2 common colds were COVID. And so I don't know what our numbers are here, but in the context of, we know that there's rampant transmission happening. We know that kids are having quick symptoms, which can peak within a day and then settle down very quickly. That can be rhinovirus, it can be coronavirus, it could be any of the old coronaviruses, which there are 4 circulating ones which cause the common cold. So we don't know right now. And I think in the context right now, it depends. Where was your 8-year-old? Was there a known contact or exposure? Was there someone else sick at home? I mean, part of it is like, you could try to do your own contact tracing, knowing that it's basically impossible right now. I wouldn't bother looking back past the last 48 hours. But what I do know is that there are a lot of people who are still accessing tests, whether it's rapid tests or positive tests. So, I mean, if in your circle someone has been infected and you've seen them within the last 2 days and someone in that group had it, it's likely that's what it was. I think that there will be more uses for rapid tests. We know that a ton have come to the province last week, and we know that they're actually very good at detecting it if you're positive, if you're symptomatic, and if the timing makes sense, then they're very good at detecting illnesses, and you can be fairly confident that they're what we call true positives, or highly sensitive tests. And so part of this will be, how do we navigate that as a society when we do have wider access to them? Who do we test? Why do we test them? When should we not test? And that's the guidance we really need to get from public health, to help us guide those decisions, because we all have our ideas on it, but I'm not a public health expert. I'm not an epidemiologist, and I'm not an infectious disease doctor or an immunologist. And those are the people I want to be learning from.
And that must be tricky, Jen, from a policy point of view in the school district. This kind of the question that was asked about, what do I do? Like, my kids do I assume they have Omicron from the point of view of sending them to school? You might, and it feels as if it hasn't been quite as clear from the sort of the provincial level as it possibly could be to help parents out with that. How does Burnaby look at that?
Well, I think every student in BC is supposed to do the K-12 daily health check, and it's a list of different symptoms. And if you have a fever, or if you have, and that's been updated, I think it's sore throat, cough, a lot of different symptoms. If you have any of those, you're supposed to stay home. I think that's where, as Dr. Narang said, if you have symptoms and you were with someone and you were close contact of somebody that had tested positive, I think that what we're hearing is assume it is and act accordingly. I think that really the piece that makes it difficult for families is that so much emphasis has now been made on personal choices and personal risk, and recognizing where you've been and what you've done, and kind of looking at it through that lens. And I think that as a parent, I look at it as being a little bit more cautious, as if my kids have a cold, you are supposed to keep them home if you can. And I think it's just the way we can protect those around us, not just our own family, but the ones that we're with, the ones that we go to school with, the ones that that we go and visit. I think that that really it's even in the last little bit, the more we can do to protect each other, that's what makes us a community. It's really helped in our schools, where people have taken that personal sense of responsibility.
That's great. Well, I think that's actually a wonderful place to leave our conversation. We don't have any more questions. Thank you, Dr. Narang, for the very, very really great presentation, really detailed, and Jen for being here, and for everything the school district is doing to navigate this, because it's tricky. And I know that I know that we're talking a lot with teachers and with families, and they just really appreciate the clarity that's coming forward, and feel as if actually I think if you look at the stats, feel as if they're pretty well protected as compared to the rest of the world in Burnaby. So it's a great thing to see. So I do want to remind folks that that this is being recorded. It will be made available to you, and please keep, and as well as there's up-to-date information that's always been being posted on the BurnabyPCN.ca website around the changes that are continually happening, and hope everybody stays safe out there and enjoys the rest of your evening. Thank you very much.